Can you start, Dr. Nora?
Yes, I think they are trying to enter the Zoom. Still, they are trying the resident. So wait like few minutes.
Yeah, maybe a few minutes. I think still we can start. It's okay. The people who will join will join.
Yeah. Okay.
11,
So we
11 people
start.
have come. It's okay. I think by some time everybody will come. You can just give an introduction and start. Yeah.
Yes. Okay. Assalamu alaikum wa rahmatullah. This is Dr. Noura Salah. So today we will talk about the pattern of the muscle disease in children. I will start with case summary and a brief introduction. And only I'll give broad line, then Dr. Akbar will follow inshallah with more details. So let's start by analyzing the case history of a child admitted in neurology team. The case discussion is still unsolved. This is regarding 13-year-old child who presented with vague symptoms from 4 years of age. He had episodic pain over both thighs and legs since 4 years of age for the past 9 years. In the last 10 days, he presented with pain and stiffness and inability to extend the right forearm, sustained flexion of right forearm for the last 15 days. So the background medical information, he was a developmentally normal child born to third-degree consanguineous parents with no adverse perinatal events at birth, had insidious onset illness from 4 years of age in the form of complaining not able to walk for a long period of time, by which he gets tired and takes rest. Initial symptoms initially were very infrequent, separated by long symptomatic interval, but then by 10 years of age, his symptoms start to be more frequent, like he's having 3 to 4 episodes per week of insidious onset pain and stiffness over both thighs and calf muscles starting by evening hours and persisting into sleep. So the child will find difficulty to sleep in night hours with pain in the legs and would require paracetamol. The next day, he will feel fine, normal, there is no pain. He would walk, run, play football. However, he would feel again tired by the evening hours due to pain and fatigability overall. He describes the pain as more of crampy sensation of calf muscle, which would settle after overnight rest. The triggers he mentioned that he's having when he had exercise, upper respiratory tract infection, fever, or exposure to cold. This can trigger his pain episodes in calf muscles and thigh muscles. He had one severe pain episode at 11 years of age, but this time, in addition to the pain, he had stiffness on both upper limbs, which resolved in 24 hours with no facial weakness, no swallowing difficulty ever. So, any clues from vast medical history that we mentioned right now? Which symptoms is not part of the past medical history in this child? Episodic myalgia, weakness, muscle cramps, or exercise intolerance. Shall I move? So, see, okay. So, the weakness is the one which was not there. He never had weakness. So, this patient, we mentioned that he was third degree consanguineous uh, consanguinity. There was third degree consanguinity. His symptoms started from 4 years of age. The symptoms, he will be tired and take rest by the end of the day after having exercise. His symptoms start to be more frequent when he reached 10 years of age, like he will present, will have 3 to 4 episodes per week. and his pain and stiffness will be more in thigh and calf muscles, never in joint, and he after overnight rest he will be fine and start to move, walk and run. And his symptoms will be triggered by exercise, UTI, fever and cold exposure. There were no weakness. So the presenting complaint, he started at 13 years of age. He was admitted with episode of pain in the thigh and calf muscle. He had gradual onset pain in both hands, from shoulder to distal area, not triggered by preceding fever or infection. The pain was ill-defined character. Moreover, elbow and forearm muscle by the next 24 to 48 hours progressed with increasing severity and swelling diffusely around mainly the right elbow and forearm muscle with inability to extend the forearm because of pain. There was no weakness in using his hands, no weakness in legs, no reddish discoloration occurring, no fever, no joint swelling or rash, and there was no history of weight loss or loss of appetite. In examination, he had no facial dysmorphism, no facial weakness, no high arch palate, no tongue fasciculation, no diffuse wasting, no joint hyperlaxity or chest wall deformity. The right upper arm was flexed at the elbow joint with local tenderness over the forearm muscle. He cannot extend the forearm and could only slowly extend his forearm because of pain. There is joint line tenderness and joint swelling, some warm. The tone were normal in all four limbs, no proximal or distal weakness, reflexes elicitable in all four limbs, no fatigability, no ptosis, no weakness. There were no scoliosis or other bony deformity. So, which positive finding in examination is likely unique in this child? The fatigability weakness in muscle, muscle cramps, muscle contraction, or muscle myotonia. So it is the muscle contraction. So here we'll go back. In the last sentence we say that he had flexed elbow with local tenderness and he cannot extend the forearm because of the pain. Well, there were no joint, there is no joint tenderness, but it was swollen with contraction. So the main positive finding here during examination is that it was muscle contraction. So overall, the child had positive muscle symptoms, which is myalgia, cramps, contracture, but he didn't have muscle stiffness or muscle hypertrophy, and he had some negative muscle symptoms, which was exercise intolerance and fatigability, but not, he didn't have the muscle atrophy or weakness. So muscle disease can produce both positive and negative symptoms. So during investigation, they had normal CK, normal ammonia lactate, thyroid function were normal, nerve conduction normal, and acylcarnitine profile was normal. Urine myoglobin was absent, and whole exome sequence was awaited, and PMG still also awaited. So here we have a lot of genes, multiple gene protein mutation that can affect muscle function and muscle structure. So what disease could likely explain his symptoms? Congenital myopathy, congenital muscular dystrophy, congenital myasthenia gravis, congenital myotonic dystrophy, or metabolic myopathy. Any idea? So our we think it is metabolic myopathy. So we'll explain here how the muscle get energy during exercise. So to get energy fuel, we have three ways. It is glycogen breakdown, free fatty acid breakdown, or mitochondrial, the respiratory chain. The glycogen to be transformed to pyruvate, it needs some steps, and during these steps we need multiple enzymes to, to facilitate this. If we have any enzyme deficiency, we'll get difficulty to transfer glycogen to pyruvate and to get energy. So the diseases with decreased muscle energy can be due to defect of carbohydrate utilization or defect of fatty acid oxidation or mitochondrial myopathies. So mainly the defect in carbohydrate utilization can give these symptoms, and here we will talk about metabolic myopathy, mainly myocardial disease. So the glycogen pathway in the first step, if there is phosphorylase B enzyme deficiency, there will be defect in breakdown of glycogen 1 phosphate to glycogen 6 phosphate, and this can present with severe muscle cramps after exercise, myoglobinuria, normal muscle mass, they will have normal muscle mass and normal reflexes, EMG will be normal, they will have high CK, high urine myoglobin, and muscle biopsy will be diagnostic with sacroilimbal vacuoles containing glycogen with absence of phosphorylase enzyme, muscle fiber degeneration and regeneration after the episodes, and treatment here will be carnitine supplement. In comparing to primary mitochondrial myopathy, their symptoms will vary based on the muscle affected. Initially, early on in the disease, they will have mainly extraocular muscle weakness with progressive external ophthalmoplegia, restricted eye movement, diplopia, double vision, and ptosis. If it gives weakness in the facial muscle, they will present with slurred speech and swallowing difficulties. If it affects the chest wall muscles, they will present with respiratory failure, and other hand and leg muscles, they will affect day-to-day time activity like walking and writing and etc. So those patients with primary mitochondrial myopathy, they present with muscle cramping and fatigability, exercise intolerance, muscle stiffness, weakness, and paralysis. The biochemical markers will show high lactate, high pyruvate, and high CK. And muscle biopsy also, it is diagnostic with red fibers, and genetic testing will confirm is it due to mitochondrial or nuclear defect. So treatment, there is no cure from mitochondrial myopathy, only will manage symptoms wise, and some vitamins will be given like creatine, antioxidant, and coenzyme Q10. Some main features of metabolic myopathies are heterogeneous group disorder affecting any age. It is inherited defect of enzymatic pathway involved in muscle cell metabolism. It could be permanent. The symptoms will be permanent, fixed, or episodic. And such as weakness, wasting, exercise intolerance, myalgia, or increased muscle breakdown, like high CK and myoglobin during exercise. Limb and respiratory muscle also frequently affected, and number of genes related, it is steadily increasing. Currently, there is more than 50 genes account for these symptoms, and treatment is limited. Still, there is no cure, only symptoms will give some help, give some help. So, we can analyze disease of muscles if we can understand only the basic structure and function. So, we'll go through some basic structure and function of the muscle, mainly skeletal muscle. Skeletal muscle give us like it provide us the framework by providing a picture. So it is energy store in addition to liver and help us to ambulate and perform movement. It is lower motor neuron unit. It's a final pathway of the lower motor neuron unit. So here from motor neuron anterior horn cell we have afferent and efferent nerves in the muscle. If we take that one skeletal muscle, the normal skeletal muscle structure, it is like it is a lot of muscle fascicles, muscle fibers. Muscle fascicles give muscle fibers, and muscle fibers consist of multiple muscle myofibrils, and there is like connective tissue enclosing all muscle fibers. It is epimysium, perimysium, and endymysium. It is consists of many proteins, connective tissue proteins, and any loss of these proteins give us muscle disease. So any protein loss affecting the connective tissue can affect the muscle function. So here we said again, the muscle function is formed of muscle fascicles, and these muscle fascicles is formed of multiple muscle fibers, and these muscle fibers formed of muscle myofibrils, and will go later to the collagen and dystroglycan connective tissue protein that encircle these skeletal muscles. And if we have defect in these connective tissue protein, we'll have muscle dysfunction. We have muscle uh, problem. So here, in the basic unit of the muscle is the sarcomere. That sarcomere is that's made of many proteins. It is also used like consists of thin filament and the thick filament. Then thin filament is actin and the thick filament is myosin. And also any protein affecting the sarcomere can affect muscle function. So here we have the connective tissue surrounding the muscles consists of muscle connective tissue, protein, collagen, and dystroglycan. And the sarcomere is the basic unit of the muscle. It consists of thin filament and the thick filament, actin, myosin, and these proteins affect also the muscle function. So, quick revision of muscle function and structure. Here we say that skeletal muscle is the final pathway of lower motor neuron unit. Crucial connective tissue proteins surrounding muscles include collagen, dystroglycan, and laminin. Sarcomere is a basic unit of muscle strand, and crucial proteins involved in sarcomere like actin, titin, and nephilin. And sarcolemma is the tubule which pump in calcium to muscle sarcomere. Key protein in sarcolemma is rhinodine, and energy fuel as source include glycogen, fatty acid, and mitochondria. So if we have genetic mutation in connective tissue protein, collagen, or dystroglycan, it will destroy muscle structure, and these disorders are called congenital muscular dystrophy. If we had genetic mutations affecting sarcomere or sarcolemma affects muscle function but do not damage muscle, and these mutations affecting protein of sarcomere cause congenital myopathies. And if we have mutations affecting the structure of neuromuscular junction, affecting neuromuscular transmission, this mutation in protein forming structure of neuromuscular junction cause congenital myasthenia gravis. So there are three main groups of muscle disease: congenital myopathy, congenital muscular dystrophy, and congenital myasthenia gravis. We say that the collagen, the genetic mutation in collagen protein that will give us congenital muscular dystrophy, and if the genetic mutation affects sarcomere and sarcolemma protein, it will give congenital myopathy, and if that mutation affects the neuromuscular junction, And this mutation in protein forming structure of neuromuscular junction, it will give congenital myasthenia gravis. So this is in brief, and for more discussion, Dr. Akbar inshallah will follow for the clinical presentation among muscle diseases. Thank you.
Yeah, you can stop scash screening, Dr. Nora. Yeah, thank you. Stop your screen share.
We stopped already.
Sorry, I need to start my presentation. Sorry, can you hear me? Sorry, one second.
Can you share your screen now, Doctor?
Yeah, it's asking for permission. Let me see, one second. Yes, one second, please. Yeah. One second. Yeah. Can you see my screen now? Can you see my screen now, Dr. Noora? Yeah,
Yes, I can see.
we can see, no? Right, okay, thank you. Okay, so good evening all. So what we started with one of the child which had recently come to us 3 weeks ago. Still not diagnosed, but we are strongly suspecting a metabolic disorder because of exercise intolerance and muscle cramps and muscle contracture. So the idea of this presentation is to say some pattern of muscle diseases. We started the last session with a floppy baby approach, and we understood a floppy baby can have multiple levels of neuroanatomical issues to cause floppiness in a baby. But in this presentation, we'll just see some of the pattern recognition within the muscle diseases. And the three major categories, as Dr. Nora told, are congenital myopathy, congenital muscular dystrophy, and congenital myasthenia gravis. So this is just an introductory topic because muscle can be really very complex. There are so many phenotypes as neurologist, but as a resident and as a student involved in pediatrics, I just want you to know the 2 or 3 common phenotypes that we see in the OPD, and they have like very good clinical features, which makes us easy to recognize them. Okay. So I don't want to scare with a lot of new terminologies, but I have no option in this presentation. I need to introduce few terminologies or few new protein names which you may not have heard before. But the emphasis, as I said, is to just say the 3 main categories and some one case each in the 3 main category. One category, one disease in congenital muscular dystrophy, one disease in a congenital myopathy, and one disease in congenital myasthenia gravis. So I just want to focus upon few classical muscle phenotypes which we can recognize in our outpatient department or emergency or PICU, wherever they come. So what Noora was trying to tell is this structure, the complex structure of the outside connective tissue, which will have a lot of proteins. Main protein are collagen, laminin, and dystroglycan. Okay, so if the outside connective tissue proteins are dysfunctional or absent because of a genetic mutation, this structure will collapse. Okay, it's almost like a building outer layer, and if the structure outer layer will collapse, your muscle gets damaged, and that is why you have like high creatinine kinase enzyme levels. Okay, once the muscle membrane gets damaged, especially this is very important complex called dystroglycan. Okay, the dystroglycan, collagen, and laminin, these are very important extracellular proteins. And when you talk about the muscle function, we have the sarcomere proteins like myosin and actin. Dr. Noora was telling them, if these gets dysfunctional, the muscle does not damage, but the muscle function becomes very weak. Okay, the power of the muscles sort of gets reduced. So these are the basic structure or the at the micro level in the case of muscle fibers. So we'll just talk about the 3 major groups of muscle diseases, okay, and I'll try to say some clinical patterns that we can identify. So before that, just a quick recap of last week's session on floppy baby. So any baby who's having extremely floppy, extremely loose or hypotonic with the head lag, with poor anti-gravity movements, okay, who's having difficulty in the breathing or having some facial or bulbar issues. We have a lot of children coming to the outpatient or the ER or PICU with floppy babies, okay. As we told, we do this basic, investigation to check for the tone. We do the ventral suspension. We do the pull to sit maneuver. Okay, you look the differences between the central weakness or the axial weakness, and you see the difference between the axial and the appendicular weakness. So, what is the first and the foremost question that we should answer when we see a floppy baby? Anybody wants to chat? One quick chat in the chat box. What is the first thing you want to observe in a floppy baby after your basic examination? Or what is the first decision making you want to take? This is from the last class. Anybody wants to give an answer in the chat? How will you divide a floppy baby, or how will you do basic division of a floppy baby? Anybody wants to answer once you see a floppy baby? What is the basic subdivision? How do you want to approach further? Right? Okay. Okay, nobody wants to chat. So basically, once you see a floppy baby, the first thing that we want to observe is, yes, weak or not weak. Excellent. Yeah. Excellent. Yeah. Central or peripheral. Excellent. Yeah. So the first question that we want to answer is that whether it is central or a floppy or a strong baby, and a floppy and a weak baby. Floppy baby has lots of causes. Okay. So the central cause, like the brain or the metabolic or genetic causes, usually babies are not that weak. Whereas if we have babies with the anterior horn cell or the muscle or the connective tissues, okay, or the nerves, they are usually weak. So the first thing we want to decide is whether the baby is weak or not weak, okay, or whether the baby is strong and floppy, and whether the baby is weak and floppy. So when a baby is strong and floppy, usually they have more of a truncal hypotonia than their limbs. The limbs can have some good anti-gravity movements, okay. They can have some facial dysmorphism, they can have hepatomegaly, they can have splenomegaly, they can have other genetic or metabolic clues, okay. Their reflexes are usually elicitable, okay. Whereas if you have a floppy and a weak baby, they have a diffuse hypotonia. They seems to be weak throughout, face, neck, limbs, everything is weak. So they have a equal degree of hypotonia. Their anti-gravity movements are pretty weak, and their weakness can have different areas. Sometimes the face may be more weak, sometimes the limbs may be more weak, okay. The reflexes are very difficult to be elicited or absent in many cases, okay. And the main three areas are anterior horn cell, nerve, muscle, or neuromuscular junction. So this, once you know it's a floppy and a weak baby, you have to decide between anterior horn cell, anterior horn cell, nerve, or a muscle, okay. So it is relatively easy to identify a anterior horn cell disorder, okay. I'm sure most of you would have seen a spinal muscular atrophy. They would have tongue fasciculations. The face is spared, okay. I didn't write here, but the face is spared. They have a very good facial expression. They have a proximal more than distal weakness. They have a atrophy and wasting. They have tongue fasciculations. The reflexes are absent. They can have respiratory failure, okay, but their face is spared, okay, the swallowing is spared until the disease progresses. And it may be sometimes easy to identify nerve disease also. It will have only purely distal atrophy and distal weakness with sensory loss, okay. Again, here also the face and the cranial nerves are spared, okay. One of the examples is Charcot-Marie-Tooth disease. But if you have a very severe nerve disease, it may be difficult to differentiate sometimes. But if you see a muscle overall, we always think muscle involving the face and the cranial bulbar nuclei or the bulbar pharyngeal muscles, okay. You can see sometimes muscle hypertrophy in some muscle diseases, okay. So muscle diseases are a little bit difficult to understand, because if you have a very severe muscle disease, okay, they can actually mimic very severe nerve disease as well. But having said that, muscle disease most of the time can show some gradient, some pattern of proximal involvement or some facial involvement and so on, okay. Fatigability can be seen in a case of a neuromuscular junction. These are the very basic differences, and all student, all resident should be aware of these basic three differences, okay. What is the difference between anterior horn cell, nerve, and a muscle, okay. There is no excuse, we should know it thoroughly. So once you know in the muscle, now the difficulty is understand what is there in the muscle. Is it myopathy or a muscular dystrophy? Okay. So let me quickly go through all the three categories, some theoretical explanation, okay, and then we'll reinforce on the clinical concepts. So the muscle diseases are three categories, as Dr. Noura told. It's muscular dystrophy, myopathy, and myasthenia gravis. We had given an idea when your connective tissue is broken, you have a muscle damage, and it's called the muscular dystrophy. Muscular dystrophies by nature are progressive. Okay, so this is the first catch point. Whereas a myopathy can be sometimes very static and sometimes even like a CP, cerebral palsy child. Okay, they can even walk. Whereas muscular dystrophies are always progressive over a period of time. Okay, there is relatively some degree of face being spared in a case of a muscular dystrophy. Okay, when compared to a myopathy or a myasthenia gravis. So this is sometimes very unique. Sometimes the face and the bulbar are not that much involved in the case of a congenital muscular dystrophy. Of course, if you do a lab test, CPK is always high. So it is relatively easy to pick up a muscular dystrophy. When you see a CPK high, we can call it as a muscular dystrophy. Exceptions are there. If you have collagen being affected, CPK can be normal. Okay. Whereas in a congenital myopathy, also in some congenital muscular dystrophies, very interestingly, your brain can be involved. Okay, in some congenital muscular dystrophies, your brain can be involved or eyes can be involved. That's why we call this as a muscle eye brain phenotype. Okay, muscle eye and brain phenotype can be involved in certain congenital muscular dystrophies, and it can confuse a mitochondrial disorder. Congenital muscular dystrophies are notorious to confuse with a mitochondrial disorder because mitochondrial disorders also involves muscles, eyes, and the brain. Okay, so that is a confusion you can have sometimes with a mitochondrial disorder. Congenital myopathies can be very CP-like, very static. Some milder ones even go to school and college. Okay, they have only a little bit of bony deformities, but they have some degree of proximal weakness. The brain and the eyes are not involved, and myopathies, as we have already told, is because of sarcomere proteins like actin, nemalin, myosin, or creatine. Myasthenia gravis, the classical ones, congenital myasthenia gravis, are easy to identify. But having said that, again, myasthenia gravis is so much variation in the presentation, so much variation. Okay, they can mimic like even all the other muscle diseases. But one clue is that they can have fatigability and reversibility. Okay, after a period of rest, the fatigability goes off, and they have predominant faciobulbar involvement than the limbs involvement. Okay, and the CPK is normal in a case of a congenital myasthenia gravis. Again, this slide is your basic summary slide. Okay, basic summary slide. At least if you can go back, take a screenshot and read the summary slide, you should be able to keep in your mind for your exams. Okay, so this is a basic summary slide. So let's quickly see about muscular dystrophies. As I told you, I just want to tell you one disease in each category, which we see in the OPD frequently. So if you come to neurology rotation, it will be easy for you to identify these conditions. So collagens, laminin, and dystroglycan. These are the three major proteins in your extracellular membrane. And accordingly, you can have a collagen-based congenital muscular dystrophy, laminin-based congenital muscular dystrophy, and a dystroglycan-based congenital muscular dystrophy, are also called dystroglycanopathies. Okay, so these are the three major categories of congenital muscular dystrophy, of which it is very characteristic features are seen in collagen disorders, and we can easily identify them clinically. Okay. So how do collagen disorders present with? Okay, so we'll just go to this. So the three main proteins are collagen, laminin, and dystroglycan. Okay, so one of the collagen disorder that we see frequently, even last year I had seen 3 children, is Ullrich disease or a collagen 6 disorder, congenital muscular dystrophy. They have a lot of clinical features. So the one of the most important clinical feature is what is known as hyperlaxicity of joints. Okay, they have hyperlaxicity of the distal joints, elbow joints, knee joints, and even the neck joints. So whenever you see hyperlaxicity, is there any other disease which is coming into your mind? Any other non-neurological disease which is coming into your mind? You can chat. Whenever we see hyperlaxicity, any non-neurological disease, can somebody chat? Marfan's very good. Marfan's disease can have hyperlaxicity. Ehlers-Danlos syndrome, excellent. Okay, so yes, so these can be confused with Ehlers-Danlos syndrome because of their hyperlaxicity joints. So one of the most common differential diagnosis or confusion comes is, oh, whether it is an EDS, okay, or Ehlers-Danlos syndrome, because there is also excessive laxicity of joints. So, but in addition to laxicity, their palms and soles almost have like a velvet-like feel, velvet cloth feel. All of you know the velvet cloth, which looks like a silk cloth, very soft feel to it, okay? Like a soft cushion pillow. So they have a velvet cloth-like feel to their palms and soles. As you can see, the degree of extensibility, okay, the degree of hyperlaxicity, I can even pull the shoulder to the opposite side, okay. So lots of hyperlaxicity of the joints can be seen in this collagen disorder. Very easy to identify clinically if you pick up 1 or 2 cases. And after a period of time, they have this sort of a fixed contracture in the elbow and in the neck. Okay, so these are the 2 areas. So they can have a fixed neck contracture leading to a rigid spine, or they can have a fixed elbow contracture like this. And they can have a rocker bottom feet, okay, with again a soft velvety palms and soles, okay, like a cloth like feel to their palms and soles, okay. And they can have in the skin this sort of hyperkeratosis, hyperkeratotic follicles in their skins, okay. And if an incision is made, sometimes that incision does not heal and they heal with a prominent keloid scar. So these are some of the good clinical features that you can make up. So if you have a child with a proximal weakness, having hyperlaxicity joints, velvety palms and soles, okay, having some contractures around the elbows, always think about collagen based congenital muscular dystrophy. So these are the key findings. So once you start seeing 1 or 2 cases, it's very easy to recognize. Directly we can order for this test and get the diagnosis, okay. So hyperlaxicity, rocker bottom feet, proximal weaknesses, very mild facial weakness. As I told you, congenital muscular dystrophies usually do not have that degree of facial or bulbar weakness, okay. And the CK can be normal or it could be very little bit raised, okay. So the other 2 are very severe, okay. If you are, there are some children coming to our ID and ICU, staying for longer periods, okay. They look like a mitochondrial disorders, very severe because they can involve your muscle and your brain. In the brain, they can involve the white matter of the brain because laminins are also distributed in your white matter as a part of your myelin proteins. So they can have this diffuse white matter changes like leukodystrophy. And these disorders are called as myrosin deficient congenital muscular dystrophy or laminin deficient congenital muscular dystrophy. So they can present with the neurological symptoms also. In addition to hypotonia, they can have convulsions. So whenever you see a child with a muscle, eye, brain phenotype, think about a mitochondrial disorder or think about a congenital muscular dystrophy. And CPK is elevated, okay? So the severest brain anomaly is seen in dystroglycan disorder. So the third protein in the connective tissue is called dystroglycan, and they can cause the severest brain disorder. See, the brainstem is almost like a thin thread, and you can have a kinked brainstem. You can have a diffuse cerebellar hypoplasia, okay? And you can have so many diseases in this called Walker-Warburg syndrome, Fukuyama disease, and so on. So one mnemonic to remember this is called hydrocephalus, agyria, retinal dysplasia, and encephalocele or hard he phenotype. Okay, severe brain malformations with severe muscle diseases are a part of dystroglycanopathies. They do not survive their infancy. Most of them die within the first 1 year of life. Okay, so these are the 3 main disorders in congenital muscular dystrophy. They are Ullrich disease, they are dystroglycanopathy, and they are laminin deficient congenital muscular dystrophy. So because of multi-system presentation, CMDs can be confused with mitochondrial disorders. So some other findings are based upon, sometimes you can see contracture, sometimes you can see pontocerebellar hyperplasia, sometimes you can see rigid spine. And some of these late onset congenital muscular dystrophies can look like Duchenne muscular dystrophy or Becker. There are very rare disorders like Foucaultin or FKRPs, okay? But just remember, if you have a child with hyperlaxicity, some contractures, some CPK which is raised, always think about a collagen-based disorder, okay? So, and a brief discussion now about the other category, which is congenital myopathy. It's because of the sarcomere proteins like actin or myosin or titin, okay? So, the severest type we see in a congenital myopathy, if you can remember, these myopathies were initially, like let us say 5 years to 5 to 10 years ago, we used to classify the myopathies based upon muscle biopsy findings because they had characteristic muscle biopsy findings, okay? So you used to call it central core disease, okay, Nemalin rod disease, okay, and centronuclear disease or so and so. But the recent classification focus on the protein, like, you know, there's a sarcomere protein actin, so they called us actinopathy, okay. There's a sarcomere protein called titin, so they called us titinopathy, nebulinopathy, and so and so. So I'm just not going into the details, just to give an idea. More and more medicine is turning towards the genetic phenotyping. I'm sure after 10 years from now, all the diseases mostly will be discussed based upon their genes only, rather than based upon their histopathology or biopsy findings, okay. But having said that, one congenital myopathy where we should be knowing is Nemalin rod myopathy or Nemalin body myopathy. the first thing that we should always keep a picture in our mind is how a myopathic face looks like. Okay, so if somebody asks you to describe me the myopathic face, you should be able to describe. So they are very long face, first of all, number one. Can you see that? And the lower part below the nose is much more affected than the upper part. Okay, and this, they have a V-shaped mouth, open mouth, right? They can have dolichocephaly. Okay, so this is a myopathic facies where the mouth is open and there's lots of drooling of saliva, and there is like very poor expression in the face with a long facies and a dolichocephaly. So most of them have these myopathic facies. Needless to say, most of them have faciobulbar weakness and proximal weakness. Okay, but if you get only faciobulbar weakness, which is like fatigable and which is coming episodically, you should also think about myasthenia gravis as well. Anyhow, so this is a picture that you should remember. So these are the proteins, as I told you. The recent classification says nebulinopathy, actinopathy, titinopathy, and so and so. I'm not going in that way, but the classical or the most severest phenotype, which we all explain, is called as a Nemalin disease. Okay, so a Nemalin disease. So what is a Nemalin disease? The severest type is called as a Nemalin body myopathy based upon the histopathology. The others are central core and central nuclei, but Nemalin body myopathy has certain clinical features. Okay. And when you talk about the gene aspects, they are either because of actin deficit or they are either because of a Nemalin deficit. Okay, these are the two main proteins affected in Nemalin. So Nemalin can be identified clinically. In addition to having a facial weakness, Nemalin also has two important findings. So Nemalin actually involves the respiratory muscles very early in their life. Okay, so these children end up in high-D or end up in PICU requiring tracheostomies. So among the myopathies, the myopathy which has significant respiratory muscle involvement is a Nemalin myopathy. Just keep in your mind. And another is that Nemalin involves the neck muscles, okay, quite early. So they have, because of the neck muscle involvement, they have unique posture. The way they keep their head and neck is quite unique, okay, like a penguin. All of you know the bird penguin. Okay, so because they have a neck flexor weakness, they sort of extend the neck backwards and keep like that. Okay, a penguin like neck pattern. Okay, so in the histopathology, of course, we see this red bodies, rod like bodies. Okay, just below the sarcolemma, and that's why it's called as a Nemalin body myopathy. Okay, which could be actin granules or it could be your Nemalin granules. Okay, so this is the prominent facial weakness. There is no ptosis. Okay, if you see a prominent ptosis, then it is not a Nemalin myopathy. That's another type of myopathies. So this is what I said. They have this unique way of keeping their neck, okay, like a penguin. Because they have a neck flexor weakness, they tend to keep their neck like extended backwards. Okay, and they have significant early respiratory muscle involvement. Okay, so if I have a child with proximal weakness with a neck flexor weakness, so if there's a neck flexor weakness, they keep their neck backwards. What happens if there's a neck extensor weakness? They will have their neck going downwards. That's called dropped neck. So it's opposite. They keep their head like a penguin. So a neck extensor weakness is opposite of neck flexor. This is another diseases. It can cause a drop head phenotype. Okay, but just remember this photo. A child who's keeping the neck extended backwards with respiratory involvement is usually a congenital myopathy, Nemalin disease. But if a child neck extensor is weak, they can drop their neck like this. This is called as a drop head phenotype. And this child doesn't even have a muscle disease. This child has a hypokalemia because of a severe diarrhea. So sometimes even if you have a severe hypokalemia, it causes a neck extensor weakness to cause a drop neck phenotype. And see, after potassium correction, the neck muscle strength is immediately recovered. Okay, so this is very interesting clinical finding called drop head phenotype seen after neck extensor weakness. Okay, but Nemalin rod disease causes neck flexor weakness and a penguin-like neck retraction, okay, or retrocollis. So the main clinical features in Nemalin. So I just want you to remember a Nemalin disease. Nemalin disease will have lower facial weakness. Nemalin disease will have a neck flexor weakness, okay, and they can have early respiratory involvement, okay, and they can have hypoventilation as a cause of death. There is not much ptosis. Very rare types sometimes can have contractures as well. One interesting muscle disease is very risky, especially when in terms of general anesthesia, which is your Rioting receptor defect. It's a protein in your sarcolemma, and this can be associated with malignant hyperthermias, okay, especially after GA. So you have to be very careful for this particular type. Ptosis is very strongly seen in myotubularin type of defect. If you want to remember, these are like one-word answers which comes in entrance examinations or any, if you are going for USMLE or other parts, they ask ptosis predominantly seen in centronuclear myopathies. Okay, all these myopathies can have fetal akinesia, especially if they are severe. Okay, so the Nemalin one is the one which is usually severe and it can produces a fetal akinesia. The mother can have polyhydramnios and they can present with the contractures. Prominent cardiomyopathy can be seen in titin. So these cardiac, even cardiac muscle is a muscle, but unlike the skeletal muscle, it's a different type of a muscle. Okay, but cardiac muscles can also be involved in a case of certain congenital myopathies. Okay. So the third category, a very brief discussion on congenital myasthenia gravis. The classical one is always very easy. Okay, if you see a child with a ptosis, the eye is not moving, some swallowing difficulty, but the child sleeps and get up, ptosis is gone, swallowing difficulty is gone. Okay, that's a fatigable weakness. It's very, very easy to identify a myasthenia gravis. But having said that, congenital myasthenia gravis is very, very different and very unique. Why so? Because you see, there are a lot of proteins which forms the synapse. Okay, so you can have a presynaptic membrane, you can have a synapse, and you can have a postsynaptic membrane. And accordingly, congenital myasthenia gravis is broadly classified into three types: presynaptic congenital myasthenic syndrome, synaptic congenital myasthenic syndrome, and postsynaptic congenital myasthenic syndrome. Now, because there are so many proteins, there is lots of variation in presentation. Okay, only the postsynaptic ones, okay, can or the presynaptic ones can have a very typical fatigability, ptosis, ophthalmoparesis, and so on. So the other proteins can mimic almost like any muscle diseases. It can mimic a limb girdle muscle disease. It can mimic a congenital myopathy, or it can mimic even a congenital muscular dystrophy. So congenital myasthenia gravis have lots of proteins. Okay, only the initial proteins like chat and musk, that is choline acetyl transferase and musk proteins, they usually resemble your typical myasthenia gravis. All the other proteins which are like anchoring proteins, the postsynaptic membrane like rapsin, doc7, they all have different types of presentation, like a limb girdle presentation or a myopathy like presentation. Okay, so this is just to bring to your notice. Okay, so don't think that if you have a limb girdle weakness or proximal weakness, it is not a myasthenia gravis. It still can be a myasthenia gravis. Okay, but the classical ones, even though if you see just a proximal weakness, but if you can able to identify the fatigability, it is still can be a myasthenia gravis. So because fatigability is the hallmark of a neuromuscular junction disorder. Okay, so as I said you, congenital myasthenia gravis is the most heterogeneous among all muscle diseases. Okay, you can present just with contractures, it can present just with limb girdle weakness, it can present even with neonatal apneas, it can present with a foot drop, it can just present with a neck extensor weakness, multiple varied presentation. But the classical one is your facial bulbar weakness with fatigability. Okay. Right. So the classical one is easy: diurnal variation, ptosis with ophthalmoparesis, facial weakness, and they are responsive to pyridostigmine. So if we doubt a myasthenia gravis, we do what is known as an heterophonium test, or we just give a dose of pyridostigmine and see whether there is response. If there is response, we can take it. It's probably a myasthenia gravis. But there are certain myasthenia gravis which can actually get aggravated by giving pyridostigmine as well, especially certain other types of postsynaptic CMS. Okay. So it's a complex topic. I'm not going into the details of the different types of myasthenia gravis. So when you have facial and bulbar weakness, always you should think about congenital myasthenia gravis, congenital myopathies, certain types, and also congenital myotonic dystrophy. So in this class, I'm not talking in details about congenital myotonic dystrophy, okay? But this is another differential diagnosis for a severe facial and bulbar weakness. So in your SCABU or a newborn, if you have a child with a lot of swallowing difficulty, okay, always think about these three differential diagnoses: congenital myotonic dystrophy, congenital myasthenia gravis, and congenital certain types of congenital myopathies. Okay, so let's just revise with the help of a Zoom quiz the three main groups of muscle diseases. Okay, like in every session, there is a small Zoom quiz after this revision. So the three main categories are congenital muscular dystrophy, myopathy, and myasthenia. Muscular dystrophy, CPK are elevated. You can have laxicity, joint laxicity, muscle, eye, brain can be involved, okay? But not much of facial weakness. Congenital myopathy has facial and weakness, bulbar weakness, possible weakness, can be very static, okay? Can be very severe in a case of a Nemalin weakness where there is a neck flexor weakness, okay? Congenital myasthenia has highly variable presentation, okay? So yeah, even before going to the quiz, I'm sorry. Whatever your muscle diseases, okay, whatever your muscle diseases, You have to take a detailed history, the antenatal history, the perinatal history, and the postnatal history. What are you trying to identify from the history? You want to know the age of onset. Okay, if the onset is quite early from the newborn period or early infancy, you should think about congenital disorders. But if the disorders are coming after 5 years or 6 years, it can be late onset muscle disorders. I'm not talking in this class about late onset muscle disorders. Okay, then you should know whether it is static or progressive. It is progressive, you should think about congenital muscular dystrophy or a mitochondrial myopathy. Okay, if it is episodic or worsening, you think about metabolic myopathies or congenital myasthenia gravis. Then you have to review, of course, the other systems, whether heart is involved, okay, whether your brain is involved, whether your eyes is involved, and so on. And there are certain symptoms unique to muscle disorders, especially they have very poor fetal movements, okay, and some of these mothers can have polyhydramnios, okay, because of impaired fetal swallowing, okay. Prominent facial weakness is a clue to muscle disorders, as we have already discussed, and because of muscle weakness, these children can have skeletal deformities. So you have lots of children with mild muscle diseases presenting just with the skeletal deformities, okay, just with the pectus excavatum or just with the pes cavus and so on, okay, or just with hip dislocation also. And yes, they can have an occult respiratory insufficiency because of weak diaphragmatic muscles as well, okay. And always when a child comes, please do this functional assessment of different groups of muscles, okay. So as a neurologist, we are interested how we can help the child. So we want to know how, okay, is there a respiratory weakness, is there a limb weakness, is there a facial weakness, okay. So by default, you should be able to tell the pattern of weakness. You should be able to tell doctor there is a weakness, but I think that the facial weakness is more than the respiratory weakness. Or you should say, doctor, there's a weakness, but the respiratory weakness is more than the limb weakness. So you should be able to find out the different gradients of weakness between the different levels, okay, whether it's a shoulder girdle, and you know that different weakness produces different difficulties. If you have a shoulder girdle weakness, there's a difficulty in lifting the objects. If there's a forearm weakness, there's a difficulty in writing, there is a difficulty in making a fist, okay. If there's a girdle weakness, there's difficulty in walking. And if there's a foot drop, you can have recurrent ankle twisting and recurrent ankle sprain, okay, and so on, okay. So always try to do a functional assessment of various groups of muscles that are involved. So we'll go to the quiz. It's based upon what we had discussed about the 3 categories, okay. It's a Zoom quiz. So which of the following is not a connective tissue protein? So this is the first point. Which of the following is not a connective tissue protein? Yeah, I'm launching the poll. So first question, which of the following is not a connective tissue protein? So we had discussed about connective tissue proteins and muscle protein. All of you can see the quiz, I think so. Or no? Can you see the quiz? Yeah, Dr. Nora, 1 second. Yeah, the first question, very good. One. Only one of you answered. Which of the following is not a connective tissue protein? Okay, fine. It's 1 minute. No, the first question is only this one. I mean, laminin, collagen, ryanodin, or dystroglycan. We are not gone to the second question, so don't answer the second question, please. Just answer the first question. Which of the following is not a connective tissue protein? Okay, the answer for this is ryanodin. Okay, so laminin is a connective tissue protein, collagen is a connective tissue protein, and dystroglycan is a connective tissue protein. The answer is ryanodin. Ryanodin is a sarcolemma protein. So which disease can explain these findings? This is question number 2. Which protein can defect these? Question number 2. So just try to answer in the poll question number 2. I think there's some difficulty because, yeah. Which protein defect can explain this particular defect? Question number 2 alone in the poll. I should have made different polls. I'm sorry for that. Most of you don't want to try, I think. So, okay, the answer for this is that it's a severe, as you can see, a severe brainstem kinking, severe brain disease, severe eye disease, encephalocele. So this is your dystroglycanopathy. Okay. So this is your dystroglycan disease. So this is the third question. a case scenario. A 20-day-old baby had delayed cry at birth with low Apgar 3 and 7, requiring intubation for poor respiratory efforts. MRI brain done was normal. Okay. Metabolic screening test. Was normal. Child was extubated on day 10 but required frequent sectioning. Child had weak cry with no tongue fasciculation. There was a droopy eyelids. Overall, the anti-gravity movements were very poor. Creatinine kinase enzyme levels was normal. Which investigation can help in diagnosis? So we have a child with the low Apgars. Okay, MRI is normal, metabolic screening is normal, extubated but lot of oral secretion, weak cry, no tongue fasciculation, droopy eyelids. So yeah, so it's question number 3. I'm starting the poll now. Which investigation can help in diagnosis? Only for question number 3, can you answer the poll? Only for question number 3. Yeah. Right, 10 seconds more. We'll wait. Maybe we'll give you some more seconds, some more time. So we need to help in the diagnosis and we need some answers and how to proceed further. This child is having a facial and a bulbar weakness. So when I said there is a facial and bulbar weakness, there are 3 disorders which can cause facial and bulbar weakness. One is a congenital myopathy, one is a congenital myasthenia gravis, okay, and one is a congenital myotonic dystrophy. Okay, so the options were divided between muscle biopsy and EMG testing, most of you. One of you wanted for whole exome, but whole exome would take a lot of time. The answer for this is EMG testing. Okay, so if the EMG testing shows myotonia, then you clinch the diagnosis. It's a congenital myotonic dystrophy presenting with the facial and bulbar weakness. Or if the EMG testing is normal, then you can think it may be myasthenia gravis or a myopathy. Okay, so the electrophysiological studies is very useful in the critical care setting. Okay, if the child is stable enough, can be shifted, can to do, because it takes hardly around 20 to 30 minutes and gives lots of information. Okay, because muscle biopsy, again, it's an invasive procedure. You have to do it, you have to wait for the results. It may take a week or so for the results to come. Okay, whole exome is the final result, but it can take, of course, 2 to 3 months for the results to be done. Okay, so the final summary. So this is an algorithm and the flow chart. Okay, so whenever you see a child with both weakness, axial and appendicular weakness, or a floppy weak baby, you should think about anterior horn cell disease, nerve disease, or a muscle disease. Anterior horn cell disease is very easy to identify because face is bad, there is tongue fasciculation, and there is a diffuse wasting. Okay, nerve diseases, they have distal wasting, okay, and face is bad again. But muscle diseases sometimes can be a bit tricky. You can have positive muscle symptoms like myalgia, cramps, contractures, myoglobinuria, stiffness. Okay, and when you have a positive muscle stiffness, you should think about a metabolic myopathy or a myotonia also sometimes. Okay, and metabolic myopathy, as Dr. Noora told, are 3 categories: glycogen, fatty acid, and mitochondrial disorders. But if you have a negative symptoms, and if you have certain clues like a rigid spine, hyperlaxicity of joints, CK being elevated, brain being involved, you can think about congenital muscular dystrophy. If you have negative symptoms but predominant faciobulbar weakness, it could be 3 category. But if you do an EMG and if you can see fatigability and decrement, you can think about congenital myasthenia gravis. And if you do an EMG and if you saw myotonia, which is like rapid burst of sound from the needle, okay, you can myotonic discharges from the muscle, you can think about congenital myotonia. Only a CP-like presentation with some scoliosis, mild deformities, with mild proximal weakness, okay, sometimes can be severe as well. You can think about congenital myopathy. Okay, so this algorithm is a fairly simplified form, but a very basic outline about how we can think about various groups of floppy disorders, but peak disorders. Okay, so I believe that everything should be made simple, but sometimes things should not be made very simple as well. Then it is doesn't serve the purpose, because if it is made very simple, then probably we don't try to appreciate the intricacies and the beautiful nature of our own human body, right? So that is the reason sometimes we need to, of course, push ourselves and improve our own standards as a student to read more about the certain complex illnesses, because I believe as a students, it's our own responsibility to go back and read. So yeah, so as a teacher, I think I try to make it as simple as possible, but yeah, it should be to some extent. Yeah. So any questions we can take. Yeah. So yeah, Dr. Aisha has asked a good question. What do you mean by negative and positive symptoms? Yeah. So it's a very good question, Dr. Aisha. So that's what in the initial case presentation, Dr. Noora was trying to tell. So a positive symptoms means rather than a deficit, the child would feel more of a pain, stiffness, cramps, and contractures. You know, the muscles are not feeling good. It is not weak. My muscles are not weak, but I'm feeling like lots of pain in my muscles. It is becoming stiff after a little bit of exercise. You know, and I'm not able to do things as normal. So it's a very vague like symptoms. But yeah, sometimes even after, like for example, there are some children who go for a school marathon or a school race or a school football game, and they end up in severe crampy pain in their muscles, and they end up having myoglobinuria and sometimes even renal failure as well because of severe rhabdomyolysis. Okay, so a rhabdomyolysis, muscle cramps, muscle contractures, muscle stiffness, and muscle pain, these are the positive symptoms from a muscle. Okay, the negative symptoms from the muscle are muscle weakness, okay, exercise intolerance, and fatigability. So these are the negative symptoms from a muscle. So this is the first way you think about. Okay. Dr. Taufik has asked a good question. When we see children with axial hypotonia and swallowing disorder, which is not progressive, axial hypotonia, swallowing disorder, which is not progressive, and some facial flatness, how do you analyze that? Okay. So the classical teaching is that if you have a predominant axial hypotonia, think about central causes. Okay. But if you have a predominant axial hypotonia with the bulbar involvement, okay, alone rather than the limbs being spared, of course, you can still think about some rarer types of myopathies where limbs are involved late, okay? But it really becomes a difficult option because it doesn't fit into any particular pattern. So we may have to work up extensively to reach a specific cause. Most likely, these children would have some rare forms of genetic or paroxysomal disorders and so on. So, because paroxysomal is notorious to produce, you know, axial hypotonias as well as bulbar dysfunction. Yeah, but can be very difficult. Yeah, I agree with that. I would think mostly in terms of paroxysmal, like metabolic disorder presenting as more of axial hypotonia with the bulbar weakness. Right? Any questions more? Right? I encourage all residents to read a Phenotypes clinical pediatric neurology textbook. It gives idea about the clinical presentations rather than reading up to date. I've seen a trend among all residents to read up to date. Up to date is an evidence-based review. It is very good if you know the subject, but up to date sometimes will not give you the clinical approach and understanding and forming differential diagnosis. Differential diagnosis comes from reading clinical books, okay, and a very good book for pediatric neurology is Phenotypes Pediatric Neurology, right? Okay, thank you, students. Thank you for attending this class. Inshallah, we'll meet after 15 days. Thank you all. Thank you all. I'm closing this session.